to discuss the physiology questions which were asked in CBT 2017. The first question which has been asked is, what is cardiac index? Now, cardiac index is defined as the cardiac output per meter squared of the body surface area. Cardiac output per meter squared of body surface area. And this is the average value is 3.2 liters per minute per meter squared of the body surface area. 3.2 liters per minute per meter squared of the body surface area. This is cardiac index. Let's see the next question. All of the following cause heterometric regulation of cardiac output except. Now, what is heterometric? Now, there are two types of, when you look at the regulation of cardiac output, there are regulation of cardiac output. There is a homometric regulation and a heterometric regulation. Homometric, the word itself should be able to give you a hint. What is homometric regulation of cardiac output? This refers to the regulation of cardiac output which is independent of the cardiac muscle length. Independent of cardiac muscle length, right? So under homometric regulation of cardiac output, anything which increases the heart rate, or anything which increases the myocardial contractility, these will come under homometric. Homo, same, metric, length. Cardiac muscle length remains the same, but there is a change in cardiac output. So the factors that can produce a homometric regulation of cardiac output is increase in heart rate and increase or decrease in myocardial contractility. So anything which changes heart rate or changes the myocardial contractility will be under homometric regulation of cardiac output, right? Anything which changes the heart rate or myocardial contractility. Therefore, now what is heterometric regulation of cardiac output? Heterometric regulation of cardiac output. Now, this includes all the factors which change the cardiac muscle length. Regulation of cardiac output by changes in, this includes, this is regulation of cardiac output by changes in the cardiac muscle fiber length, right? Cardiac muscle fiber length. So this is hetero, different, length, metric, length. So this is regulation of cardiac output by changes in cardiac muscle length. Increase in venous return will increase the cardiac muscle length. Increase in end diastolic volume will increase the cardiac muscle length. Increased ventricular filling will cause an increase in the cardiac muscle length. If you look at this, this is the ventricular muscle here. All these three factors will increase the cardiac muscle length, right? And this will cause an increase in the tension generated up to a physiological limit. This is as per the Frank-Starling's law. But increase in myocardial contractility will increase cardiac output without affecting the cardiac muscle length, right? So this comes under, this is homometric regulation of cardiac output. Changes in contractility will cause a homometric regulation in cardiac output. Let's look at the next question. During exercise, a man consumes 1.8 liters of oxygen per minute. His arterial O2 content is 190 ml and his oxygen content of his mixed venous blood is 130 ml per liter. His cardiac output is. Now, this is the calculation of cardiac output, or this is the cardiac output by the Fick's principle. This is cardiac output by the Fick's principle. Cardiac output by the Fick's principle. And what is a Fick's principle? This says cardiac output in liters per minute will be equal to the oxygen consumption. Oxygen consumption has to be in ml per minute, divided by the arteriovenous, O2 difference. Arteriovenous or O2 difference, but this has to be in ml per liter. So oxygen consumption has been given to you as 1.8, so about 1800 ml per minute, divided by arterial oxygen has been given to you as 190 ml per liter minus 130 ml per liter. This becomes, this your answer is 1800 divided by 60, 1800 divided by 60, which is equal to 30 liters per minute. So your answer to this question becomes 30 liters per minute, right? So this is the cardiac output by the Fick's principle. Let's look at the next question. The work done by the left ventricle is significantly higher than the right ventricle even at rest because the work done. What is the definition of work done? What is work done? Work done is stroke volume into the mean arterial pressure. Stroke volume into the mean arterial pressure. The reason why the work done by the left ventricle is more than the right ventricle is mainly because the left ventricle pumps blood into the systemic circulation, which is a higher resistance circuit as compared to the pulmonary circulation, right? And higher resistance means greater afterload. Greater afterload means the higher resistance, higher mean arterial pressure, greater afterload, greater will be the work done. Right? So this is the work done by the left ventricle is mainly because of this. Since the resistance faced by the left ventricle, resistance which has to be against which the left ventricle has to do work is more than on the right side, left ventricle therefore has a thicker wall because the afterload for the left ventricle is greater than that on the right side. Let's look at the next question. The lung volume at the end of a maximum inspiration, at the end when the lungs are fully inflated, when the lungs are fully inflated, the lung volume at that particular point will be equal to the total lung capacity. And total lung capacity in the case of males is about 6,000 ml, and in the case of females about 4,200 ml. What is inspiratory capacity? Inspiratory capacity is includes the tidal volume plus the IRV. Forced vital capacity is IRV plus tidal volume plus the ERV. Forced vital capacity is the volume of air expired forcefully after a forceful inspiration. So it includes IRV and tidal volume plus ERV. Functional residual capacity is the volume of air present in the lungs at the end of a normal expiration. And functional residual capacity is ERV plus the residual volume. Total lung capacity is the IRV plus tidal volume plus ERV plus the residual volume. So it includes all the volumes. This is the total volume of air which is present in the lungs at the end of a maximum inspiration. Next, all of the following are effects of hyperventilation except. All of the following are effects of hyperventilation. Now, as far as hyperventilation is concerned, hyperventilation typically produces a CO2 washout, right? It produces a CO2 washout. And CO2 washout, that means the arterial PCO2 may fall to as low as 15. From a normal of 40, it may fall to as low as 15 millimeters of mercury. Alveolar PO2 will increase because hyperventilation also means increase in alveolar ventilation. Increase in alveolar ventilation means alveolar PO2 will increase to 120 to 140 millimeters of mercury. Cerebral blood flow in fact reduces. Why is this? This is because hypocapnia, a decrease in PCO2, causes a vasoconstriction of the cerebral blood vessels, right? It causes a vasoconstriction of the cerebral blood vessels. And because of these, cerebral blood vessels, and these in turn will lead to a lightheadedness. There may be dyspnea, there may be dizziness, paresthesias, right? These are typically seen in cases of because of the hypocapnia. Hypocapnia reduces a vasoconstriction of the cerebral blood vessels, which in turn leads to lightheadedness, dizziness, paresthesias, right? This is the effect of hyperventilation. But what will happen to the pH of the blood? The pH of the blood will increase. It causes a respiratory alkalosis. It produces a respiratory alkalosis. So acidosis is not a possibility. Acidosis is not a possibility. Let's look at the next question. Lactic acid is given intravenously. This increases the rate and depth of ventilation. Now, lactic acid, H+, which is the most potent stimulus, most potent and the direct stimulus for the central chemoreceptors. Where are the central chemoreceptors located? They are located on the surface of medulla. The most potent direct stimulus for the central chemoreceptors is H+. But please remember that H+, if the H+ increases in the blood, right? If there is increase in H+ in the blood, it fails to act on the central chemoreceptors because present between the blood and the surface of the medulla is the blood-brain barrier. And this blood-brain barrier is formed by the tight junctions between the endothelial cells. This H+, which increases in the blood, cannot cross this blood-brain barrier, so it cannot affect the central chemoreceptors, right? But now this increase in H+, will be able to affect the peripheral chemoreceptors. So the lactic acid, the increase in H+, will now affect the carotid bodies. And carotid bodies, once they are excited, they will increase the rate and depth of ventilation. They increase the depth of ventilation, right? Now, remember these stimuli for these peripheral chemoreceptors. What are the stimuli for peripheral chemoreceptors? The most potent stimulus for the peripheral chemoreceptors, that is carotid and aortic bodies, is of course hypoxia, but also increase in PCO2, increase in H+, decrease in pH, increase in lactic acid. Increase in lactic acid will not be able to affect the medullary chemoreceptors but can affect the peripheral chemoreceptors. Even an increase in K+ and cyanide. Cyanide can also directly affect the peripheral chemoreceptors. So these are the stimuli for the peripheral chemoreceptors. Next, maximum calcium reabsorption occurs in which part of the nephron? Maximum calcium will be absorbed from the PCT. The PCT, the amount of calcium absorbed from the PCT is almost 2/3. That is about 65% is absorbed from the PCT. About 25 to 30% is from the thick ascending limb. And the calcium absorption in the DCT is about 4 to 9%. And this is under the control of parathormone. And less than 1% is going to be, less than 1% of the filtered calcium. Less than 1% of the filtered calcium is actually excreted, right? Almost 99% of the filtered calcium will be reabsorbed, and these are the site, but the maximum calcium reabsorption takes place in the PCT. In the DCT, it is under the control of parathormone. Let's see the next question. This says gastric lipase is produced by which of the following cells? Now, oxyntic or the parietal cells. Oxyntic or the parietal cells they mean the same thing. These secrete HCl, right? The chief cells, which are also known as the peptic cells, these are involved in the secretion of pepsin and gastric lipase. The enterochromaffin cells or enterochromaffin-like cells, these are involved in the secretion of histamine. Histamine will act on H2 receptors on parietal cells and increase the HCl secretion. So the answer to this question becomes your chief cells. Next, let's see. The largest daily secretion is from which of the following? Largest daily secretion is, in fact, if you look at the saliva is approximately 1 liter, so about 800 to 1200 ml per day. Gastric secretion is about 2000 to 2500 ml per day. Bile, which is secreted, is approximately 500 ml per day. Right? Pancreatic secretion is about 1500 ml per day. Right? 1500 ml per day. So my best answer here becomes stomach. Gastric secretion will be the highest as compared to the others. Let's see the next question. This is, which of the following neurons of the cerebellum secretes glutamate? Now, glutamate is an excitatory neurotransmitter, and the only neuron which secretes glutamate will be granule cells. Granule cell is the only excitatory neuron in the cerebellum. This is the only excitatory neuron in the cerebellum. Right? Only excitatory neuron in the cerebellum. All the others are inhibitory. So basket cells, stellate cells, Golgi cells, Purkinje cells, they all secrete GABA. GABA is the inhibitory neurotransmitter. Let's see the next question. This says, all of the following are true about short-chain fatty acids except. Short-chain fatty acids are produced in the colon by the action of colonic bacteria on complex carbohydrates, resistant starches, and dietary fiber. Yes. These 60% of the total short-chain fatty acids is acetate. That is also true. In fact, 25% is propionate. %15 is butyrate. Right? So this is also true. These are absorbed in the colon. Yes, this is also true. Now, are they absorbed by sodium short-chain fatty acid co-transport? No. Right? These are how are SCFAs absorbed in the colon? They are absorbed by specific transporters. There are some specific transporters. There are specific transporters present in colonic epithelial cells. Colonic epithelial cells. Right? Specific transporters present in colonic epithelial cells. Which of the movements does not occur in the colon? Peristalsis, yes, occurs in the colon. Segmentation contractions occur in the colon. Mass action contractions also occur in the colon, where large segments of the colon contract together. And this is especially important in movement of fecal matter. Migrating motor complexes do not occur in the colon. This migrating motor complex is a ring of contraction. This is a ring of contraction which starts from the body of stomach. This is a ring of contraction which starts from the body of stomach. Right? This starts from the body of stomach and goes right up to the distal ileum. It goes right up to the distal ileum. Right? This is a migrating motor complex. Next, which of the following neurons innervate the extensor alpha motor neuron? The moment it says extensor alpha motor neuron, that should give you a hint that this is involved in posture. Right? The innervation of flexors is, especially upper limb flexors, is mainly for fine skilled movement, but extensors mainly for maintenance of posture. Now, if you see the reticulospinal tract innervates A gamma especially to the extensors. This is responsible for responsible for mainly the extensor tone. That is your reticulospinal tract. There are two types of reticulospinal tract, pontine or an excitatory tract, and the medullary or the inhibitory tract. Pontine tract increases muscle tone, especially the extensor tone, and the medullary tract will inhibit the extensor tone. Lateral corticospinal tract innervates the A alpha, but mainly to the flexors. Because remember, flexors are involved in fine scale movement, especially flexors of the upper limb. Rubrospinal tract again will be A alpha to the flexors, and rubrospinal tract and the lateral corticospinal tract, they're both involved in fine skilled movement. On the other hand, vestibulospinal tract, this will innervate mainly the A alpha to the extensors. This is involved in maintenance of posture, right? Involved in maintenance of posture. Let's look at the next question, and this is: the circuit below shows an inflow pressure of 120, outflow pressure of 40. Resistance in each of the following vessels is 2 millimeters of mercury per ml per minute. What is the total peripheral resistance? Now, total resistance over here will be, this is 1 upon R is equal to 1 upon 2 plus 1 upon 2 plus 1 upon 2 plus 1 upon 2, which is equal to 2. So R will be equal to half. So my answer becomes 0.5 millimeters of mercury per ml per minute. The importance of this is, whenever you have circuits in parallel, the total resistance will be lower than the resistance of the individual circuit. If you have circuits in series, then the total resistance will be the sum total of the total resistance will be higher than the individual circuit. In this case, and the significance here is, you know that the systemic circulation is divided into a number of parallel circuits, and having circuits in parallel means there will be a decrease in the total peripheral resistance.